But there's a trend here that shows that there has been some development in this indicator over the course of 1 year. If we go down and look at cohort 2 or cohort 3, the pretest was done on admission. The first post-test was done at midpoint in the program. And if you notice, the scores go from 62 to 60. And you say to yourself, they're losing this trait. They're losing on this measure. But if we back up and look at what's going on in this first year, you have a student that's coming in who has been an expert as an ICU nurse, successful in that role. They have all the cognitive abilities that we desire. And now they are having to transition into a new role. They are having to transition into a student role that is out of their ICU nurse expertise. They're down to ground zero again. And the level of stress in this nurse anesthesia program is off the chart. That's what we're thinking is behind this drop for the first year student. The end of the first year, somewhere in there going into that second year, they're getting their feet on the ground. They know what their role is. They're a bit more functional in that role, a bit more comfortable as an anesthesia provider, not an ICU nurse. And so we see that other score bounce up. So we're thinking that there might be that dip as they come in, get hit full on with everything that they have to do in a new role, and then as they settle into it, then it starts picking up. So keep that notion. The next one is trainability. And again, if you look at the scores, you see that same trend. The ones from midpoint to the end show an increase. And the cohort 3, they come in first right off the bat. And 1 year later, they show a dip. Intriguing notion. Basic insight. This is the only one that had a significant t-test, and that was only in cohort 3 or cohort 2. And what we see is that their growth, and I'm going to call it growth, but that shift to the positive came in basic insight, and it came over the course of their second year in the program. So phenomenal growth in this area. However, for cohort 3, they still take a dip in this indicator. And if you look at cohort 1, which was the group that was just getting ready to graduate, they're not much different than cohort 2 at graduation. Critical decision making. Again, if you look at cohort 2, they dropped here. They increased here, which is maintaining that same trend that we identified in the other indicators. However, look at cohort 3. This is for the first time an indicator that increased in 1 year's time, where in all the other indicators, they were losing ground. In critical decision making, they were making ground. They were moving forwards. And if you think of what this indicator is, they are growing in the area of being able to make decisions. We're putting them in the OR, and they're having to make more decisions with supervision than they've ever made before in the clinical setting. Okay? Intriguing notion. Qualitative judgment. Now this is interesting. When you look at cohort 2, they drop. And when you look at cohort 3, they drop. Now, if you look at what this indicator is, it's being able to take in qualitative data in your world around you. They're in a new world, in a new role that is incredibly stressful without unknown outcomes. Maybe it takes a bit more time to develop this indicator into a growth. Because if you look at cohort 1, as they were getting ready to graduate, look how much higher it is. So this is something that we need to really be aware of, that we're losing a little bit of ground in this area. And so we have to ask ourselves, how can we help students enhance or grow or develop in this area? The next one is quantitative judgment. And again, if you look at cohort 1, look how much further ahead they are compared to cohort 2 and 3. Again, we don't have anything to know before that point in time for them. Look at cohort 2. They maintain this trend of growing in their ability to process quantitative data. Cohort 3, again, it's the same trend that they're losing a little bit of ground here during that first year. And this, again, is a critical indicator for these students. So what did we learn? It's a small sample, it's a pilot study, and there's more to be done. The norms have to be established. We're working on that, obviously. We are adding students as new students are admitted, so we're continuing to grow in the study. An interesting notion that Vikus was able to point out for us, they have a huge data bank on ICU nurses. When our students were compared to them, their quantitative and qualitative scores were significantly higher than the ICU nurses. And that was the pool that they came out of, because they all come out of some ICU setting. So an interesting notion. Another notion, we really became more aware of the degree of stress that the students are under. We take it for granted. We live with it. It's sort of there and you don't notice it. But it really brought to our awareness the impact of the stress on the students, especially that first year. And we need to go back and look at that again. Secondly, I think for our part as faculty, we have a better understanding of judgment and decision making. One of the things that has sort of been a premise for us in the past in nursing is students come in with judgment and decision making ability. They either have it or they don't. And really what we're finding out is that they have it to some degree. The question, instead of whether they have it or not, becomes how do we help them grow in these areas in their professional development, whether it's undergraduate or graduate students. Interestingly enough, when looking at individual student results, the anesthesia students are evaluated daily by their preceptors in clinical practice. Every single day of practice, they're evaluated by preceptors. And it's interesting because what the preceptors have been saying verbally, the Hartman is supporting it on an individual basis. Where a student has the cognitive ability and they're not performing well in clinical, and then we've stopped and looked at an individual student results, and you can really see those deficits identified with this tool. It is such a sensitive tool. And We did have a statistical consultant to help us with all the other statistics that we did. And that is the end. My curiosity is to hear what you have to say about what we're doing. Any thoughts about what we're doing?
When you find a student who's having problems, what do you do to help that student compensate for those problems?
Actually, several things. We try to really identify what's going on, first off. Then they meet with faculty and talk about what's going on. Are there issues at home? Are there issues elsewhere that are impacting? Many of them move from out of state and leave their families wherever they came from. So there's a lot of vulnerabilities, I'll call them that, wherever they. If it's issues of clinical performance, really trying to figure out what's going on. And many times it comes down to judgment and decision making. ICU is much more of a regimented practice. Whereas anesthesia, you're an independent practitioner making decision based on the data you see, minute by minute by minute. So it's a different quality of practice. Yes?
Can you help me with this? On the clinical side, you have those who make it and don't.
Yes.
You can dichotomize them. So what's the difference in terms of HVP scores? What differentiates?
But maybe if we identify it early on, we can work with them so that they don't drop out.
Well, I'm not asking that question.
Oh.
You've got those who make it and those who don't clinically.
Yes.
And that means you can get HVP scores on two populations.
Yes.
What's the difference?
What's your question? The reason they haven't compared the two groups is because they have HVP scores on only 3 people.
That's not enough to really examine it anymore.
Well, okay.
I would also tell you that the patterns that Miriam has seen and have revealed themselves in the work that's gone forward is precisely the same kind of patterns that we've seen in residents that we've helped with the Hartman, going into the programs and following through the programs at the University of South Florida in their School of Medicine. And they're asking the same kind of questions that Miriam and her colleagues are asking. What kind of stressors in the program itself, by about midway through the program, are causing a deterioration in these critical indicators on
the
Hartman?
first thing that comes to mind is culture shock. You've got a
That's a
cognitive
piece
culture
of it.
going to a clinical culture.
That's a
That
piece.
transition is that's bad.
It's hard.
You've got to get the clinical in sooner, and you've got to taper. You've got to have a more merciful transition from the clinical culture to from the cognitive to the clinical.
And
okay.
that's something we just did. We introduce it now with shorter clinical hours sooner in the program.
Yes, of course. It's obvious.
And that's helped.
Now, I'm looking at part 1 and part 2. Part 2 is personal.
The self.
And do you have a sense that it's the part 2 scores that are differentiating winners and losers on the clinical side?
I think it impairs their ability to work at their full potential.
That's a general statement. But does your preliminary data suggest that it's the part 2 personal scores that most differentiate those who succeed clinically and those who don't? Preliminary.
I would agree, yes.
Thank you.
But, but it's followed by a but, then we need more numbers.
Well, hey, that's assumed. That's a given.
Yeah.
That's a given. I'm trying to mine something here.
Yes.
All right. I'm finished.
Okay, thank you. Yes, sir.
Do you have a special program for the best students in this?
Do we pull them out separately? No. Because if you look at them, they're pretty close at the top.
Probably the next step will be to work with these high performance team studies, the best students, to develop complex projects because
And
they are identified. You have who are the best students and the worst students, and probably the next step will be to work with the best students.
And one of the
develop
things we
high-performance projects.
And one of the things we want to be able to do is know it before they start.